Welcome back to Catalyst University. My name is Kevin Tokoph, and in this video, we're going to be talking all about assessment of the first rib. It turns out that assessment of the first rib is not just as simple as pushing on it, seeing how it moves, if it's normal moving or if it's stiff. There's actually a lot more that goes into the assessment, and we're going to talk about that in this video. In the following two videos, we're going to be talking more about the treatment, one of which is manual, and the other are more banded mobilizations that the person can do on their own. So make sure to check out those videos after this one. Now, no discussion of the assessment of the first rib is complete without doing a brief review of the anatomy of the first rib and the associated structures in the vicinity. Now, the first one I'm going to highlight there is the clavicle, the collarbone. And then underneath that, from an anterior perspective, which is how we're viewing the image, we have the first rib. Now, the sternum, which is also shown there, has two superior attachments. The most superior you can see there is the clavicle, and then directly underneath that is the first rib. So when you're looking at this from the front, the clavicle is above the first rib. And as the clavicle goes laterally and as the first rib kind of curves around as it heads toward the spine, more specifically the T1 vertebra, there's a space in between the clavicle and the first rib. That is called the costoclavicular space. And what you can see there is there's a number of structures that actually traverse through that costoclavicular space. We've got the subclavian artery, we've got the subclavian vein, and then very importantly here we have the brachial plexus. So a bunch of nerves as they go from the neck and ultimately go down into the upper extremity. And you could imagine that from a neurological perspective, if that costoclavicular space was narrowed, it could potentially impinge some of those structures such as the nerves and lead to symptoms going down that particular arm. Now, what you also see here is some muscles that originate off of the neck vertebra. We've got the anterior and middle scalenes, and between those is the interscalene space. Now, the nerve roots that come out of the neck, and by the way, if they were pinched at the level of the nerve root in the neck, that would be consistent with a cervical radiculopathy, but I digress. As those nerve roots converge into nerves, and as they exit the neck, they've got to go between those two scalenes through the interscalene space, and then they pass through that costoclavicular space, and then ultimately underneath the tendon of the pectoralis minor, the subpectoralis minor space. Now, the normal movements of the first rib are generally speaking tilting up and tilting down, up and down. And there's certain normal movements that will cause the first rib to tilt upward. Those might include, first of all, inhalation. When we inhale, particularly when we use these accessory muscles, the first rib is going to tilt up. If I were to take, in this case, the right shoulder and just lift it up, first rib is going to move upward. If I tilt my head away from that side, so in this picture it'd actually be left side bending, that will also cause the first rib to tilt up. And then if you do the opposite of those, exhalation, bring the arm down and tilt the head back to neutral, the first rib returns back to its normal position. So there's a natural upward and downward movement of the first rib. But what can happen is sometimes that first rib moves up a little bit too much and it sort of gets stiff at the costotransverse joint where it articulates with the T1 vertebra. And when that happens, you tend to have a propensity for dysfunction. Now, first rib dysfunction pertaining to hypomobility. This is a grossly underrepresented component of the education in PT school and medical school. Generally speaking, most physical therapists that I know are generally completely unaware that this can be a major contributor to some people's dysfunction. A lot of patients have been told, oh, it's your neck, it's your shoulder, it's your upper back, and that's what they come in for. And in many cases, I would say most cases, it is the neck, it is the shoulder, it is the upper back. But there is a lot more cases than you would realize where the primary pain contributor and what's contributing to dysfunction is the first rib. And so understanding what is going on with it and how to assess it becomes extremely important. Now, I'm going to group first rib dysfunction into three categories, okay? The first category is probably what you would see most of the time. It's the person actually has a true neck issue, or they've got a true thoracic spine or a true shoulder issue. And the first rib is stiff, but it's not the primary thing. It's just an incidental finding. It's an impairment that may have some small percent contribution to what's going on with the patient as a whole, okay? Should you address it? Absolutely. Is it number one on the radar? Maybe not, but it's there and you should address it at some point. Group number two is where you absolutely have a hypomobile first rib, and that is the primary pain generator. And that should be the first thing that you go after. It's not the neck, it's not the shoulder, it's not the upper back, it is the first rib. But in this case, it's not actually causing impingement of nerves and leading to symptoms down the arm. And that's what I usually will refer to as first rib non-radicular syndrome. And group 3, you might be able to guess where this is going. This would be our radicular syndrome, where the patient will actually have usually 2 complaints. 1, pain at the first rib. 2, some type of radiating symptom down that particular upper extremity, like numbness, tingling, pins and needles, shooting pain, maybe even grip weakness. And in some people, the arm symptoms are worse. In some people, the first rib symptoms are worse. In some cases, they may just have, or at least complain of, the arm symptoms and kind of be more or less unaware that the first rib is actually too painful, because all this in the arm is masking what they're feeling at the shoulder area. So we need to understand how to assess this very precisely and very systematically. That's what we're going to get into right now. And we're going to begin by talking about pieces from the assessment for non-radicular syndrome. So this would be the case when the person does not complain of any numbness, tingling, pins and needles, shooting pains, anything like that down either of the arms. Now, of course, I'm going to probably start with cervical range of motion, flexion, extension, side bending, rotation, quadrant, right? I'm going to do all sorts of neck tests. Right, I might screen shoulder range of motion, but these are some things that we need to consider, okay? And number 1 is the patient may complain of proximal pain in any of the following patterns, okay? So pain in the first rib region. When I'm thinking of the first rib region, you can see a picture right there on the screen. This is in the vicinity of the upper traps, okay? A lot of times this particular pain is just tossed up to upper trap tightness. Everybody's got upper trap tightness, upper trap pain, myofascial pain in the area, right? But it's not necessarily the upper traps. It could be the first rib, and we'll talk about the assessment of that in just a few minutes. They may have pain with neck movement. A lot of times contralateral side bending, active range of motion. So in other words, if it was a left first rib tilting the head to the right ear to right shoulder, that can be a motion that oftentimes exacerbates that first rib pain. And let's talk about why that is right now. Let's consider for a moment right first rib dysfunction. Let's suppose that I have the patient, whether it's actively or passively, side bend their neck to their left, okay? When we do side bending of the neck, really any motion, we think of it as purely neck, but there is always a little bit of CT junction motion. So imagine this is the plane of the CT joint. It can either tilt to the left or tilt to the right. When I perform left side bending, there's always a little bit of left side bending of the CT junction. And what that does a lot of times is it will cause the first rib, let's say that's right here, to tilt up a little bit, okay? Back to neutral, left side bending, right first rib tilts up. And if that first rib tilts up excessively, particularly with a stiff costotransverse joint in the back, that could reproduce the patient's familiar pain. And that's why contralateral side bending is more likely to cause it than some of the other motions, okay? It's not to say the other motions don't, but contralateral side bending is a big one. They may also have pain with overhead shoulder motion. So for example, for a right first rib, lifting this arm up really in any plane, flexion, abduction, scaption, may reproduce their familiar first rib pain. Because remember, contralateral neck side bending along with just lifting the arm up, that is causing the first rib on that side to tilt upwards. And if it's already stiff at the costotransverse joint, that can trigger that familiar pain. And number 2, there will be a cluster of signs and symptoms that we're going to discuss now, and the more of these that are positive, the more likely you are dealing with a hypomobile first rib. Now, of course, we want to rule out the neck first as a primary source of dysfunction. So we look at neck range of motion. We look at maybe neck strength, do a screen of manual muscle testing. We get the patient in prone, do some prone PAs on the segments. Maybe it's in supine, segmental assessment there. But ruling out the neck in terms of contributing to their pain. It still could have impairments, but assuming that we don't think that it's the primary source, then we can move on to assessing the first rib. And one of the things that, of course, the person will have is pain located at the first rib on the affected side. And I will be sure after I go over the verbiage here to show you a demonstration of all these things so that you can reproduce these on your patient. But understand that for a patient with a true neck issue or true shoulder issue, you can certainly have a hypomobile first rib and it's just not creating a lot of pain. But if there is pain located at the first rib on the affected side, it's very likely that you're dealing with a first rib issue. And how do you do that? Well, you can do it sitting, you can do it supine, those are the two most common positions, and you literally just poke on the first rib. And assuming you're on the first rib and you spring it and it reproduces their pain, it's probably a first rib issue. Second thing, first rib pain reproduction with maximal inhalation. Okay, this is as simple as it sounds. You have the patient take in as much air in as they can possibly get in. Remember, when you inhale, particularly maximal, where you're using these accessory muscles, the first ribs are all going to come up. And if it's stiff, it can reproduce their pain. I would only expect this test to reproduce their pain if it was very severe. For your low severity, low irritability cases, I'm not going to expect that to reproduce the pain, but for highly severe, it actually can, believe it or not. And if I have somebody who's very severe, very miserable looking, that's probably the first test I'm going to do. I should have put that one first in the list and then move on to very gentle palpation. Okay. And then we've got a positive CRLF test, cervical rotation lateral flexion test. This is a test that can look for hypomobility of the first rib, and I'll be demonstrating that in just a minute. And then the last thing is just a hypomobile first rib, which you detect upon spring testing. If it's hypomobile, and especially if it reproduces their pain, again, more likely that you've got a hypomobile first rib as the main source of their dysfunction. And in case you're wondering, the difference between the first thing on there and the fourth thing, the first one there, I'll usually do it while they're sitting after I screen neck range of motion, and it's just a very light push on the first rib. I'm not so much assessing for stiffness, I'm just assessing for, is that painful? And then eventually when I get them in supine, that's my preferred way to do it. If they can tolerate it, I'll do the actual spring testing there to really get a feel for, is it hypomobile or not? Let's take a look at that test sequence right now. Okay, so this is a rundown of some of the tests that I use when I'm assessing a first rib, but there's no radicular symptoms, no numbness, tingling, anything like that down the affected upper extremity. So I'm going to be assessing this on her right first rib. Now, presumably I would have already had her go through cervical range of motion, maybe I do some strength testing, whatever it is. But while she's in sitting, I'm just gonna get a rough idea if the first rib is painful or not. I could do a mobility assessment here if I want to do it in sitting, but my preference, if the patient can tolerate it, is doing it in supine. It's just a more accurate assessment. So what I'll do is, on both sides, but I'll do one at a time, I'll actually find where the first rib is. And I usually use my second MCP right around the proximal phalanx, and I just put some light pressure on it, and I ask, is that spot particularly painful? They say yes, no. If it is painful at that spot, that gives me a clue that we might be dealing with a first rib. Now, what I will then move on to while the patient is sitting is I will have them through the mouth take a maximal inhale and get all the air in you can possibly get in. Go ahead, do that. And then blow everything out. And I might have them do that, 1 to 3 times depending on the quality of it, if it's good or not. But realistically, because the anterior and middle scalenes attach on that first rib, and we're taking a maximal inhale, so we're using those accessory muscles, if there is particularly very severe, very irritable first rib pain and dysfunction, sometimes that maximal inhale at the top of it usually is where it'll occur. That may actually reproduce their familiar pain. Again, like I said, for low severity cases, I don't expect that to, but usually will run through that, okay? The next test that I will do is the CRLF test, the cervical rotation lateral flexion test. So if I'm doing this for the right first rib, remember that the direction of rotation is contralateral. So what I will do is I will passively rotate her head to the left as far as I can, and then I'm going to side bend that ear down towards the sternum, okay? Now, technically, when you're doing this test, The literature says that a hard end feel is a positive test, and certainly it is. But I also use a lot of other information that I gain from that in my assessment. Even if it's not a hard end feel, if it reproduces that familiar pain, to me, that is very valuable information. Again, it would indicate that potentially we're dealing with a hypomobile first rib. Now, it could just reproduce some neck muscle tightness. That would not be a positive test for this cluster, but still useful information. Now, if we run into a situation where we're rotating, that's all we got because the neck muscles are tight, it's not going to be a valid test. They have to have pretty good cervical rotation for this to be a valid test, okay? And remember, this would be specifically testing the right first rib. So that is the CRLF test, okay? The last test in this cluster would just be to spring the first rib. Now, when I did this sitting initially, I was just trying to get a feel for if that spot is painful. I could go in at that point and just do the spring test here. Again, I prefer doing it in supine, but if they couldn't tolerate supine, I'll do the first rib spring testing in sitting. So I'll show it here first. What I would do in this case is I would side bend their head a little bit towards that side. And then I'm going to, again, using my second MCP near the proximal phalanx, I'm going to spring inferiorly. And I'm at the first rib on the part closest to the CT joint, the costotransverse joint at T1, okay? And I'm seeing how mobile it is. And then of course, I'm gonna compare that to, if the other side is unaffected, the unaffected side. Is there a different side to side? And if there is no different side to side, is it that they both move well or are they both stiff and I need to mobilize both of those? So right here, I'm going to show you how to assess mobility of the first rib in supine. So I'm going to be assessing her left first rib. So I also want to make sure with my right hand that I'm cradling the occiput of her head so I can control her head with my right hand. What I will usually do when I'm doing this is have the head slightly side bended toward that side, toward the left, and then slightly rotated away. You don't have to have it exactly like that. That's just a personal preference of mine. What I'm going to do is with my second MCP right around that proximal phalanx, I'm going to contact her first rib. One way you can think about it is if I just take my hand right under here and I just slide it right under. Unless the person has a huge amount of thoracic kyphosis, if you just slide it right there, the second MCP should contact the first rib. If the person has a huge amount of kyphosis and or a significant amount of upper trap tightness, you might have to do this in sitting. It's going to be really hard to hit that first rib without just having to dig in with your thumb, and that's not comfortable. So my direction is I am aiming this toward the contralateral ASIS, the contralateral hip. And I don't want to be contacting the first rib too laterally near the acromion. I want to have it a little bit more medially, so I'm assessing more that costotransverse joint where it articulates with T1. And once I've got good contact there, I'm just springing it, driving it, and gliding it towards, in this case, the right ASIS, okay? And then, of course, we would test this on the opposite side and compare side-to-side differences. Now, for that little cluster there, the more of those that are positive, the more likely that you're dealing with a first rib dysfunction, assuming that you've ruled out the neck and the shoulder and other things as the primary pain contributor. But remember, you could also have a neck issue or a shoulder issue, and the first rib is stiff, and you know that because you spring test it. And if it's stiff, it may be something that you want to address, maybe not the first thing if the primary issue is neck or shoulder or upper back, but you could at some point address it, and you probably should. If it is the primary issue, you probably want to start with that. And that's where we get into treatment. And that's going to be the topic of the next two videos, so make sure to check those out. Now we're going to switch gears and talk about first rib radicular syndrome. And the main thing that distinguishes this from non-radicular syndrome is the presence of radiating symptoms down one or both arms. Now, the vast majority of the time, it's just going to be one arm. I've only seen one case where it was both arms, and it was a lot worse on one side. Normally, one arm at a time. And those symptoms can include numbness, tingling, shooting pain, pins and needles, even some weakness in grip or other muscle groups, right? Our job here is not to assume it's the first rib or to assume it's a radiculopathy. Our job is to find the source of the nerve impingement, rule out the other things, so we can prove to ourselves and the patient that our treatment is going to be accurate so they can have the highest chance of success. I can't tell you how many patients I've seen with a first rib radicular syndrome that have been told it's your neck by doctor after PT after PT, and it's not. And if they had just learned this stuff and done a thorough assessment, they would have easily seen it's not the neck, okay? Now, we'll get to the neck in just a minute and talk about ruling out that stuff. But the first thing that becomes very important is actually in the subjective. It's the pattern of upper extremity symptoms. And it's particularly helpful, maybe not fun for the patient, but helpful when those symptoms go into the fingers. Makes our job a lot easier. We need to determine if this is a dermatomal pattern or a peripheral nerve pattern of nerve entrapment. Or maybe it's indeterminate. Maybe it's just a weird pattern, but it's not dermatomal. And that's where we default to a slide that looks like this. And hopefully you have this memorized. And if you don't, hopefully soon you have it memorized. And learning these patterns is very important because if the patient has a pattern of radiating symptoms that matches up with a dermatomal pattern, it is more likely that it's going to be a pinched nerve in the neck at the level of the neural foramina, so a cervical radiculopathy. Of course, we have to test with Wehner's cluster to prove that, but it makes it more likely. If the patient has a pattern that's not dermatomal, it makes it more likely that it's coming from, let's say, the first rib, a peripheral nerve entrapment pattern. So one common thing that I've actually seen is these three fingers have numbness or tingling or something like that. There is no dermatomal pattern that gets digits 2, 3, and 4. Okay? I've also seen 2, 3, 4, and 5. Okay? These are not dermatomal patterns. Now, if you have it in the thumb, right, and a little bit into the radial side of the forearm, that might be more dermatomal, right? That looks like more C6. But when you have these patterns that don't look dermatomal at all, these flashing lights and bells ought to be going off in your head that say, I need to test Wehner's cluster, but it's looking like it might be a peripheral nerve pattern. This is very valuable information that needs to be considered. And then that leads us to Wehner's cluster. We need to test Wehner's cluster looking for the potential for a cervical radiculopathy. Now, if it is a first rib radicular syndrome, most of these tests will be negative, or at a bare minimum, the cluster will be inconclusive, okay? If these tests are positive, especially Sperling's, right, it's probably a cervical radiculopathy. But let's dissect this. So for a first rib radicular syndrome, we're going to expect a negative Sperling's test. And again, we'll go through these tests in just a minute after we get through the verbiage. A negative Sperling's test, okay? Cervical rotation is likely not limited or equally limited bilaterally. So for example, in a cervical radiculopathy, let's say I've got pain down my left upper extremity and numbness and tingling. Maybe my right rotation looks pretty good, but my left rotation is limited. That's part of the cluster. The affected side rotation is limited to less than 60 degrees. Now, if both sides are equally limited, I still call that a negative test. Like if this side is 40 and this side is 40, we can't conclude anything. It's when the affected side's rotation is less than 60, but still limited compared to that in the opposite direction, okay? And then the distraction test, where we're trying to create space between the vertebra in the neck to relieve compression on the nerve. It will usually be negative with radicular syndrome here for the first rib, but understand that some patients will actually report an easing of symptoms, okay? That doesn't necessarily mean that they have a cervical radiculopathy. Again, remember that there's always different points of potential compression on the nerve. It may be that there is a tiny amount of decreased space there in the neck, but the vast majority is coming from the first rib. And when you lift the neck up, it does a little bit, just enough to relieve that compression, but not enough to qualify it as a cervical radiculopathy. And especially if Sperling's is negative, more likely to be a first rib. ULTTA, upper limb tension test for the median nerve, will probably be positive. Okay, I wouldn't use that as a judge. Again, you've got a nerve entrapment. ULTTA is probably going to be positive, but it's when Sperling's test is negative, especially, and distraction test is negative, and there's no difference in cervical rotation, that we start to say, okay, Wehner's cluster is looking like it's negative. This is not a cervical radiculopathy. And then at that point, I'm going to move on to more testing of the first rib. Now, for first rib radicular syndrome, of course, they're going to have radiating symptoms down the arm. But remember, they may also have pain associated at the first rib. And so just like with non-radicular syndrome, we're going to expect pain in the first rib region. Again, commonly mistaken for upper trap tightness. They may have pain with neck movement, especially that contralateral side bending, right? Pain with lifting the arm up in any plane. Those are still very common things, even with the radicular presentation here. And then again, there's a cluster of signs and symptoms that the more of these that are positive, the more likely you're dealing with a hypomobile first rib that is compressing the nerves in the costoclavicular space. There's a lot of overlap here with the non-radicular case. We've got pain located at the first rib on the affected side. We got the first rib and or radicular symptoms and pain reproduction with maximal inhalation. Again, usually I would only expect this with the severe cases. The low severity cases, low irritability, not so much, but it is something to potentially test. They may also still have a positive CRLF test. And with that CRLF test, that can not only reproduce pain here, it can also reproduce symptoms down the upper extremity. And either of those reproductions I would count as a positive test, as we'll see in just a few minutes. They will also have a hypomobile first rib upon spring testing, and then they may also have what we call a positive reverse Sperling's test. This is executed in the same way as Sperling's test, but it's a very different result that you likely did not talk about in PT school, and we're going to talk about it right now as we go over these tests one more time in relation to radicular presentation. Let's talk about it right now. Now we're going to run through the cluster of tests for the first rib, assuming that it is a radicular presentation. So maybe down her right upper extremity, either there is some now, or we might be able to aggravate some numbness, tingling, pins and needles, shooting pain, whatever it is. Initially, this is going to look fairly similar. So some of these I'm just going to go through very briefly and just talk about any differences. The first thing I might do is a little rib springing. Not necessarily assessing for mobility. Is that particularly painful? If it is, positive test. That says that, hey, we have some pain associated with that first rib. But again, remember, I want to make sure I'm very accurate on that spot, okay? I would then have her take a maximal inhale through the mouth. Get in all the air that you can possibly get in. Go ahead. And then blow all of it out. Now, with a radicular type of situation, that could, with, again, very severe, very irritable cases, that could reproduce pain at the first rib. It could cause some radiating symptoms. Either of those I would consider a positive test in that case. We also have the cervical rotation lateral flexion test. Again, if I'm doing that, maybe I'll show it for the left side this time, assuming it was a left-sided dysfunction, or we're just testing the unaffected side. It's always contralateral rotation. Again, remember, this test is only valid if they have a sufficient amount of rotation, and then we side bend down, okay? CRLF test. Now, if I was doing this for that right first rib, and we're going this way, this test could certainly reproduce some first rib pain. That would be a positive test in my book for this. It could also reproduce some radiating symptoms down that upper extremity. That's also a positive test. Now, one other test that we don't do when it's a non-radicular case is Sperling's test. And this maybe we would already have done as ruling out a cervical radiculopathy as part of Wehner's cluster. But again, for this example, let's suppose there's potential for radiating symptoms down the right upper extremity. So if I'm ruling out a cervical radiculopathy, I'm still going to do both sides, but here's what I would see if it was first rib. I'm going to tilt the head back into slight extension, right side bending, so ipsilateral side bending, and then I'm going to apply an axial load straight down. And if this was a radiculopathy, I would expect some radiating symptoms down the arm. But if it's not a radiculopathy and it's more the right first rib, I'm not going to expect anything down the arm on that side. However, here's the interesting thing. When I test the other side, extension left side bending, and I apply the axial load down here, sometimes, not always, that will reproduce radiating symptoms down the right upper extremity. And that is what I've come to call a reverse Sperling's test. So just because you're here doing a Sperling's test and you get radiating symptoms down that side, that is not a positive test in terms of Sperling's test. It'd be negative for a radiculopathy. But on the opposite side, a reverse Sperling's test, that sometimes happens when you have radicular symptoms due to a hypomobile first rib. Now, we've already talked about why contralateral side bending of the neck can induce first rib pain on the affected side. But now we're talking about radicular syndrome and a reverse Sperling's test. So let's say I perform a left Sperling's. What would that look like? It would be a little bit of extension, left side bending, right? And then of course I'd be on the patient's backside, but I'd perform an axial compression down. If the person had a cervical radiculopathy on the left side, that would cause the nerve symptoms to radiate down because I'm compressing the space where the nerve is on the left side. But in radicular syndrome of the first rib, let's say it's symptoms down the right arm, so we already have that left side bending there, but the axial load down further tilts that CT junction and further elevates that first rib and further narrows the costoclavicular space. So if there's a nerve impingement there, it may actually be reproduced during that test down the arm. And then of course from there, I'm going to actually spring the first rib, and that means I'm going to tilt the head a little bit towards that side, and I'm going to, again, proximal phalanx near the second MCP, I'm going to see how that first rib is moving, springing it inferiorly and slightly medially. And as I'm doing that, again, I'm assessing for the quality of motion of the first rib, but also assessing, is it painful here? Does it cause symptoms down the upper extremity? Any of those cases, particularly with hypomobility, also a positive test. Now, assuming that you've ruled out a cervical radiculopathy, the more of those tests that we just saw that are positive, the more likely that you're dealing with a first rib radicular syndrome. And if you're confident that's what's going on, it's time to talk about treatment. Now, the details of the treatment is going to be the topic of the next video, but I want to do a quick framework here before we go to those. So we've got first rib non-radicular syndrome and first rib radicular syndrome. In both cases, the first rib is hypomobile. In one case, it's just not compressing nerves. In the other case, it is compressing nerves. So we're going to do first rib mobilizations. There's manual mobilizations, there's banded mobilizations, and there's also mobilizations that you can do with a barbell, believe it or not. I'll be talking about those as well. And there's also contributing factors to why the first rib is hypomobile in the first place. We've got limited thoracic and cervicothoracic junction mobility. Remember that the first rib attaches on T1. Any CT junction deficit is going to predispose you to having a hypomobile first rib. So those are things we need to address. Postural strengthening. A lot of people with first rib dysfunction have absolutely terrible posture. Honest to God, rows, your external rotation exercises that open things up there are fantastic for people with this type of issue. There's also stress management. How often do people suck at breathing, particularly using the lower zones of the lungs? We call it belly breathing or diaphragmatic breathing. It doesn't mean we're just using the lower zones. We're using lower, middle, and upper. But so often we live in a panicky, anxiety-prone society. And when you have that type of breathing that's up here and not down here, you're going to have excessive use of these accessory muscles like the scalenes that attach on the first rib. And over time, it just draws that first rib up and makes it more likely to become stiff in that elevated position. So if the person requires stress management strategies, absolutely, it's in our job description to discuss those. Now, if it's beyond our scope, we can make a referral, but there are some things that any physical therapist can start addressing, and I have a video where I talk about that I will try to put a link in the comment section of this video. And then also cardiovascular exercise. How could that help? Well, if you don't use a muscle, it gets weaker. Now, truth be told, the diaphragm, thoracic diaphragm, is always being used. When you're sleeping, when you're not thinking about breathing, you can contract the diaphragm voluntarily or involuntarily, right? But if you're very sedentary and not getting a lot of challenge on your cardiopulmonary system, the diaphragm could actually get a little bit weak. And if the diaphragm gets weak, some of these other muscles are going to have to compensate. Now, is the diaphragm ever going to get so weak that you're just going to stop breathing? No. But these muscles can start to contribute when the diaphragm is very weak. And again, pull that first rib up and you get stiff. So any exercise that really taxes the cardiovascular system, so that could just be simply cardiovascular exercise like running, using a treadmill, elliptical, things like that. It could be sprint training. It could be resistance training, particularly resistance training that is very high intensity. All those things are going to make it less likely that your diaphragm is going to be weak and less likely that these guys are going to have to take over the function of breathing. Okay? So those are all things to consider. Now, for first rib radicular syndrome, we also have a nerve involvement. So you might also consider nerve glides. Generally speaking, either median or ulnar nerve glides will do the trick. You just kind of have to see what the person is able to tolerate. I've never had to give a radial nerve glide, ever. Maybe you want to give a radial glide, but median and ulnar seem to work the best for me. So just sharing my experience and expertise there. And hopefully this video gave you a good framework for assessing the first rib. And in the next couple of videos, we're going to be talking about treatment. The first one's going to be over manual techniques. The second one's going to be over more self-exercise techniques with banded mobilizations and barbell mobilizations. So join us then. Please make sure to like this video, subscribe to my channel, and hit that notification button for notifications for all videos in the future. Thank you so much.